Welcome, Quinn Haisley, to the Dish with Dina podcast. I'm so excited for our conversation today. Thanks so much for joining me on here.
Of course, I'm excited too.
We were just talking about how you and I share a profession as registered dietitians, and we're also sharing a profession as educators. So, will you tell our
Yes.
audience a little bit about who you are, where you're at, and what you are currently doing? And then we'll dive a little bit deeper.
Yeah, absolutely. So I currently live and work out of New York City. I live in Queens. I also teach in Queens. So I work mostly full time at my private practice, Practice Serious Nutrition, which is all virtual. Love the work from home life. And then I also teach part time at LaGuardia Community College for their nutrition and culinary management program. So I usually teach their Intro to Nutrition course and then also their nutrition counseling course.
I am very much appreciative of that whole conversation because nutrition counseling we're going to get into in a little bit too with this discussion. I feel like as students through the curriculum, it's one of those things that could we ever get enough of that? And sometimes we don't get any. So
No.
I definitely want to learn more about how you what your take is and what you're teaching the students. But go a little further back here for a sec, Quinn. What even got you interested in the health sciences and or dietetics in particular?
Yeah, so I feel like it is relatively common in the nutrition field to not have started out in nutrition. Like when I was in my master's program, I think there was only one student in my cohort who had like started in nutrition and was still doing nutrition. Most of us had a different background. So I got my first degree, my bachelor's degree in philosophy with a minor in women's and gender studies. So definitely different than what I am currently doing. But I had been really interested in health in general, even while I was in school. I had like thought about doing something aligned with medical field. I wasn't sure. Ended up in philosophy, which is definitely very different. But I actually taught educate like health education classes to high school students when I was in college. So I still got to have some of the health education that I really enjoyed while I was in college. And then I worked for the city of New York for about 3 years in their conflicts of interest board agency. So again, very different than nutrition. And was looking at going back to school. I was thinking about getting a master's for a while in public health because I had worked for the government. I was still interested in health. And as I was doing that and learning more about different education programs, master's programs, I got really interested in the idea of doing nutrition. I think it's something that I've always been interested in. I definitely had my own history with disordered eating, and I feel like doing nutrition and having my education has helped me exponentially with that. So I went back to school and actually got an associate's degree in nutrition first, and then went on to get a master's degree at NYU in clinical nutrition, did my dietetic internship there, and then actually got hired spring of 2020, right when everything was shutting down for my first nutrition job, which was interesting. And I worked at an eating disorder outpatient clinic in Manhattan for about 3 years and then transitioned to private practice. And that's what I've been doing since then.
I definitely want to ask you some questions around the outpatient, or what was the eating disorder was outpatient center
Yeah,
treatment center.
outpatient. Yeah, it was a partial hospitalization program, intensive inpatient outpatient program, and then just regular outpatient nutrition counseling.
Okay, because we've had conversations on this podcast before. So not everybody that comes on here, as I'm sure you've seen, is a dietitian. A lot of people are in the health and wellness space in some way, shape, or form. But sometimes it's a bit tricky to recognize signs. And as a dietitian, we first of all, it's a little bit outside of our scope to be a behavioral therapist, but also to sometimes pick up on those keen, nuanced behaviors that might kind of throw us off, especially if somebody is not necessarily even aware that they have a disordered eating issue or doesn't want to
Yeah.
disclose it. So, what made you feel confident about that? Because I know we don't get a lot of training in very specific, like niche populations. So, what did you do
Yeah.
to kind of prepare yourself for that role?
Such a good question. I am a firm believer that I think all dietitians should get training in eating disorders because I think that even if you're a dietitian who is not going to work in the eating disorder field, you will come across clients and patients who have eating disorders and disordered eating. And so I think even just having a comfort level of how to talk to somebody about that is so important. I know that when I first started working in the eating disorder field, had huge amounts of imposter syndrome. I definitely did not feel super confident, but some things that were really helpful. I did take an eating disorder class at NYU so that I had some background in that. For my dietetic internship, we had our community rotation and we had like a decent amount of ability to request locations that we could go to for the community rotation. And so I requested to intern at the outpatient clinic that I ended up actually getting hired at so that I could get some background during my internship. And then I also, for my electives in my master's program, took applied psychology classes so that I would have some background in psychology because that is a huge thing. I mean, I have learned so much from people who are therapists, social workers, counselor. Like I get supervision from them because I feel like it is so important for me to have that information, especially working in the eating disorder field. But that was very important and I think very helpful for me to take some classes in psychology.
I really appreciate this discussion because when I first started out, I was a little bit nervous about the counseling stuff. I didn't want to say the wrong
Yeah.
thing. And I know we often encourage students to get involved or join groups, et cetera. And I thought, well, okay, no offense to other dietitians, but I kind of don't want to just be always in those Facebook groups or those dietetic practice groups. I did start following licensed clinical social workers and therapists because their language is very similar to the things that we would use. And also, just as a side note, some of their insurance billing concerns and issues are also somewhat related to what we have to deal with too. So I
Yeah.
love that it's, you're not necessarily thinking outside the box, you're thinking alongside in a parallel way when we have this discussion around like interdisciplinary team approaches or coordinated care.
Yeah.
And I love what you also mentioned too about the supervision. So that's something too that isn't necessarily automatically baked in to the dietetics profession, where it is with behavioral therapists and people who are planning on going
Yeah.
off to be private practitioners. So how do you go about doing that? Did you get a mentor? Did you just, do some digging around, or was it said to you, if this is the path you're taking, here are the resources for you?
It was a little bit of a mixture of things. At the outpatient clinic that I was working at, we had built in supervision. So it was a little bit every other week. One day a week, we would have supervision, and like twice a month, it would just be with the dietitians who were working at the clinic. And twice a month, it was actually with, for anybody who works in the eating disorder field, Jessica Setnick is like a relatively well known person in the field. And she was doing supervision with us, which was so helpful because she is very very good at educating people, I think, especially people who are like newer to the eating disorder field. So I got supervision from her. So working at the outpatient clinic, it was more built into the job that I was doing. Since leaving, I have also joined a collective called the Kintsugi Therapist Collective. And I was the first dietitian to join the collective. They have some other care workers, but mostly it's therapists who are in the collective. And I did a like year-long program with them where we would meet and talk about cases and talk about specific topics. And then I do once a month continued supervision with them as well, which is again is like mostly with therapists.
I mentioned to you earlier that this podcast episode, we always kind of take into account that the audience could be either a colleague of ours or a patient of ours. And, we're also human, so we could also be patients of and needing care too. So just to
Yeah.
clarify some of the terminology, whoever is listening to this, I think the takeaway that I want people to understand is number one, how are we defining clinical supervision? What does that even mean, look like? How often are you meeting with your supervisors? And then in the patient's realm, like something to understand about that is to know that your healthcare provider should be keeping on top of things and should be savvy. I feel like a lot of times people are like,
Yeah.
I've been in this for 30 years and I know what's up. And they forget that they still should be working on keeping current, because there could be some harmful language. You could be setting people back who have been recovering. There could be some trauma, obviously, in there as well. So, would you mind defining a
Yeah.
little bit about what that even means, what that looks like, both as a patient would want to maybe know, and also maybe as a fellow colleague or someone who's interested in eating disorder specialties might want to know what that looks like for you?
Yeah, absolutely. So supervision, I think what's helpful for patients or clients to know is first off, it is HIPAA compliant. I feel like that's probably a fear maybe for some people that we're like going to be talking about all of their nitty gritty and everything about themselves. But usually what it looks like from the experiences that I have had is either one designated person brings a case study into supervision, or they bring in a specific topic, or it's just kind of like an open forum of whoever has something that's coming up for them that they would really want to talk about. And for the patient side, I think it's helpful to know that your providers, if they are feeling stuck with anything, if they feel like they want to be educated on something that maybe they aren't fully educated on that's coming up for them, that they have people that they can turn to help get educated on it. I think it's especially helpful so that our clients and our patients don't feel like they have to educate us on everything. That if there's something that my client is saying that I don't know enough about and I need some more education on, that I have other people that I can turn to besides just relying on my client to educate me about everything. From the more professional student side, for supervision, really what it is just any sort of, again, topic specific case that I'm working on that is feeling difficult, that I'm feeling stuck on, that I just need some like validation and support on. That's what I go for. And again, it can be one-on-one, it can be with a group, it can be with a variety of different professionals. So it can look a bunch of different ways, which I really appreciate.
Especially if you end up flying solo, like some of us in the private practice
Yeah.
world, it's very isolating here. So it's nice
Yes.
to run through things or get in touch with people who might be a little bit more experienced than we are. I know definitely for me, I don't specialize in any one thing. As a matter of fact, sometimes there's too many things going on at one time. And I was writing down as you were speaking, we have the continuing education activities that we have to comply with anyway to maintain our credential, but it can be outside of things that you may or may not think that align with what your interests are. Like you were mentioning, Quinn, like, yeah, okay, this is something that I have a specialty in, but I'm also curious of how the language is being used. And so again, stay curious, stay open to things that may be all, like if you're always integrating things that are directly related, then you don't allow yourself kind of like that outside view or scope. So be curious about juggling a few things. If you're in food service all the
Yeah.
time, check out a little clinical thing once in a while. If you're in clinical stuff, go check out some of the specialty, sports nutrition things or something else that might feel a little bit outside of what you do. Just again, to see what's out there and that can help broaden our understanding of the general population because, right, Quinn, people are complex. Not everybody's just one thing all the time. So
Oh.
I think it helps with that. So Quinn, let's go into what a current week or I was going to say typical. I always say probably it's not typical. What's a current week in the life of you these days?
Currently, I teach 2 days a week. So on Monday and Wednesdays in the like morning and early afternoon, I go in to teach. And then the rest of the weekdays, for the other times of like Wednesday and Monday afternoons. And then throughout the day, Tuesday, Thursday, Friday, I usually have clients. Occasionally, I'll have other meetings, definitely talking with other like treatment team members for my clients. So therapists, doctors, other professionals. And it kind of varies week to week how many clients I have. I like to keep it so that I'm not super overwhelmed with it. I feel like my sweet spot is like 15 clients a week. That's like that feels good. That feels solid. I'm not going to burn out from that. So yeah, the most of the rest of the week is going to be a mixture of meetings and seeing clients one-on-one.
Most of it is, or all of it is virtual, and it's
Yeah,
always
all
one-on-one,
telehealth.
or are there sessions where you might have more than one person or a group if there's, a young person with a parent or a couple that might want to be curious about how they can support each other?
Yeah, every once in a while, I don't work with adolescents anymore, but I used to more often. And that would definitely be the time that I would more often have more than one person in a session, would be when I had an adolescent and parents. I do also once a week run a LGBTQ eating disorder support group. So that is a group session. Yeah, that's like a weekly session where I have a small group of people who are in there for an eating disorder support group.
And this is insurance-based, self-pay. How do you manage the kind of like the administrative stuff that you're doing?
I am all self-pay, which I have thought about doing insurance. It's something that I still kind of think about doing from time to time. I have found that for my practice that I can keep enough clients and client load to not necessitate having insurance. I do think that having a pretty specific niche helps with that not needing to take health insurance. But I did, this year is the first year that I've implemented tiered pricing for my clients. So it goes like 75 and then it steps up different tiers to 175, which is like my full fee. And then I also have equity pricing. So if people can afford to pay a little bit extra, they can pay a little bit extra for helping to pay for the people who can't afford to pay full price for my fees.
This is what I'm also really happy to see in our profession, especially with private practitioners. So again, for anyone who's listening to this as the patient end of things, this is why sometimes it's a little difficult for us to run our businesses and also take
Mm.
insurances because there's such a wide spectrum as to what is or is not covered. And a lot of people have
Yeah.
heard me mention this on here before too. I do take insurance and I also take self-pay, whatever makes it work is fine by me. But I will have as two examples. I'll have somebody who I think has a very complex situation, is in very much need of intense and regular and consistent care. And their insurance company, while it's a $0 copay, will limit them to 3 visits. And I'm like, what can I possibly get done with that?
Not enough.
And even if I meet them once a quarter, like I'm not letting them fly solo in between. And then we also have people who have zero copay, unlimited visits, no referrals needed. And then we have the luxury of meeting, 2.5 hours if we want to during some of these sessions. And so I share this because it's not as easy as people think. And then I'm not even getting
Mhm.
into the coding and billing. So, Quinn, this might be something you can speak to about as well. When we have some of these more specific, complex/sensitive cases, and sometimes the insurance companies want us to meet a certain criteria, you know where I'm going with this, certain criteria as to what they will or will not cover. As a healthcare provider, that's where it really frustrates me because I don't want to have to say, oh, they only have coverage or we can only give them services if they meet a certain, weight or category. And so share with
Yeah.
us a little bit about your thoughts on that too. Like, do you see anything coming down the pike as where there could be more flexibility or advocacy for us to be able to
Yeah.
provide services? And if not within the insurance realm, what other options do people have to do? So, you just mentioned too with tiered pricing. So if they are looking for things that are out of pocket, some of the things that are
Yeah.
available to them, you can give them some insight into that.
Yeah, absolutely. I mean, it is hugely frustrating to me when insurance companies won't cover healthcare that I believe is absolutely necessary. And like you said, it does not always have anything to do with how complicated somebody's healthcare is or anything. Like it is just off of these numbers that insurance companies are going off of. Unfortunately, for eating disorder coverage, a lot of times the insurance companies do want weight and they're basing it off of things like BMI or ideal body weight. And especially for our clients who are in larger bodies, they get refused coverage a lot of times because the insurance companies have a lot of weight bias and they are more likely to cover for people who are in like the lower BMI categories. And I do think that there are shifts coming. There was actually a bill, and I don't know the exact specifics of it, but there was a bill that was passed in Colorado last year that has shifted what the insurance companies are allowed to use as far as insurance coverage for eating disorders so that it's moving away from using BMI and IBW to like deny people health insurance coverage. So I'm really hoping that that will be a good example for other states to work off of when it comes to specifically in coverage for eating disorders.
I am crossing my fingers for all of that too. I mean, I
Yeah,
really,
yes.
again, I tend to get on soapboxes whenever I'm here on my webinars, but whatever. My next question is about some of the things that well, I don't know how much time we have to talk about this, but some of the things that you feel might be sort of hot topics, whether it's stuff that you're excited to share about within what you are doing in the circle in which you're working or the patient population in which you're working, or things that kind of grind your gears that you would like to dispel or clarify. You choose.
Oh
Pick,
man.
pick your own adventure, Quinn.
I feel like I would rant for too long if it was things I'm frustrated about. I also have so many soapboxes that I get on about everything. I will say that the two things that I, going into my job, did not even think of as things that I would focus on that have like now become things that I focus on. One is avoidant restrictive food intake disorder. It is a newer diagnosis. It was added to the DSM in 2013, so it is like the new quote unquote new eating disorder diagnosis. And so I have started seeing really a huge portion of my population that I work with are adults who have late diagnosed avoidant restrictive food intake disorder, who have always just been called picky eaters growing up. And they were like, I've just always been like this. And my parents just thought I was picky and everything. And come to find later, like, oh, you have avoidant restrictive food intake. That's what's happening. So that's definitely been one of the bigger things that I have seen coming into my practice.
I have just entered in, so I'm nowhere near qualified to really work with people who need more intensive treatment, but I am starting to be very conscientious of the questions that I ask and really being able to feel comfortable screening. So I've been a dietitian for almost 9 years now. And like I said, I'm with whoever needs me, come see me. But a lot of what I do is I kind of screen and assess and say, if I'm not comfortable with this, I want to refer you out. So as I'm learning to pick up on things, and just like you, Quinn, I've tried to attend a lot of things. At first, I was like, no way am I ever getting involved in eating disorders. And just like you said, hello, pretty much everyone probably has some form of it or a disordered thing that has plagued them for quite a long time, even if they don't realize that they could be categorized like that. And so I'm picking up on some of the nuances. I'm getting to understand a little bit better with the language and then the treatments as well. And I've actually started working or reaching out to some outpatient centers too. If I'm just like, I really don't think that I'm okay with this, and where else could I send this person? As I shared earlier, and for people who are have been following this podcast, I am also the campus dietitian. College students who are undergoing a million different things and juggling all the stuff and don't really have maybe access either financially or location wise to quality foods, or cramming things and stressing out because there's a lot that they have to juggle too. So as the dietitian on campus, I'm also kind of keenly aware, and I guess in people from the counseling center. So we have a full-time counseling
Mm-hmm.
department in the building, and they'll send me people that they're starting to notice signs. Can I help them support that? So again, I'm okay with it at this point, but ask me 5 years ago, I'd be like, no way. If I even see a sign of that, I'm
Sure.
going to freak out.
Yeah.
But I feel a little bit more comfortable. And so what you were explaining, just like what you said, right? ARFID, RFID, we sometimes call it avoidance restrictive, is yeah, so picky or selective eating, and there are some distinctions among those things. That is so just like with GI issues, that
Mhm.
sort of situation can be figuratively and maybe literally painfully long process to kind of get through, because there's a lot of
Yeah.
challenge and trial and error and relapse, etc. Can you walk us through a little bit about like maybe your primary approach of how you're working with people just to maybe put them at ease, or at least a lot of times I think people want the quick fix and they might not be
Yes.
ready to kind of like buy into this is a commitment. So walk us through a
Yeah.
little bit about like how you as a dietitian approach it, and then also if a patient feels like they're struggling, what they might be able to expect if they're working with somebody like you.
Yeah, absolutely. I mean, I think what's so interesting, especially about ARFID, is that we have this idea with eating disorders of what like recovery from an eating disorder looks like. And I do not think that it applies in the same way to ARFID, because a lot of my clients who have ARFID, a lot of it's connected to things like the specific tastes or textures of foods. It could be connected to like traumatic events like choking or gagging on specific things. Talking about GI, some of my clients developed ARFID secondary to having GI conditions that led to like significant pain and discomfort that then caused ARFID. So there's a lot of things that can cause ARFID to become an issue for somebody. So I think that recovery is going to look different for everybody, kind of depending on what the like trigger was for their ARFID. And I like to have that conversation with clients about like, let's get to where we feel like this might be stemming from. And treatment is going to be then based off of where we feel like it's stemming from. And with my clients, I think a huge thing for ARFID is client autonomy. I always want my clients to feel like they are the ones steering the work that we are doing, just because the like quote unquote gold standard, I am not a huge fan of this term, but gold standard care for ARFID a lot of times is exposure therapy with different foods. And I have had a lot of clients who have had pretty traumatic experiences with exposure therapy that in the long run were just detrimental to their food intake, and it made them relapse, or it made them actually like lessen the amount of foods that they were able to eat. So I find it to be really important to have lengthy conversations with my clients about their quality of life goals, like what are we hoping to get to in the long term. And then if we do decide to use things like exposure therapy, just because it is like a relatively common form of treatment, what is that going to look like, making sure that they know that they can stop things at any point, that they can tell me that they do want to do something or don't want to do something, that I'm not going to just be the professional who tells them exactly what they have to do all of the time, because I find that it's never beneficial for somebody for me to just constantly tell them exactly what they should be doing.
1,000,000%. And I love, I mean, you would think, right, patient-centered care, why is that an issue? But sometimes that's how
Shocking.
people were trained back in, different generations. And some people still adhere to those things. This is the format. Here's the handout. Follow this. Come back. I'm going to yell at you if you didn't do these things. I may or may not believe what you're telling me, even though it's your lived
Yeah.
experience. And so I think
Yes.
in there too is the discussion around if you have been, a veteran embedded in the profession of whatever, pick your whatever healthcare profession you're in, of making sure that you're checking your implicit biases, you're staying on top of things, you're allowing yourself to be open-minded, you're listening and believing your patients. And then as the patient, if you feel icky, if somebody's not treating you right, I realize too, this could be a little bit of a privileged thing to say or to do, but see if you can get a different provider because it's not fair that
Yeah.
otherwise you're not even going to go. You're not going to go and be like, that guy makes me uncomfortable or this person keeps yelling at me or whatever. Like, why would you continue going to someplace like that? They're not invested in, like you mentioned, what's the quality of life? What's the true outcome that is sustainable and maintainable, like, as the years progress, not just for 3 months while I'm meeting with you, but hopefully lifelong. Let's talk a little bit about marketing, how and if social media plays a role. Like, where do you feel you get the most bang for your buck or return on investment or the what we call like the conversions of things? Like, do you make efforts with some groups and then you expect them to sign up for your email list? Like, tell us a little bit about your whole business plan, if you have one, and what that looks like for you.
So I do some form of social media. Instagram has been my biggest social media presence just because I find that it's a good way for me to do sort of like longer form written educational material, which I have found is probably some of my best marketing on social media has just been doing educational material on Instagram and then people seeing it and finding me and reaching out to me because they've seen some of my educational material and felt like it applied to them. As far as on the more professional side, I'm in some of the like professional Facebook groups, I'm on some professional listservs, but I have found that my best marketing has been with therapists who are not necessarily in the eating disorder field, because a lot of times the therapist will be working with clients and the client bring up something about food, eating, disordered eating, body image, and the therapist just knows that it's outside of their scope of practice, like it's not within their wheelhouse to work on eating disorders. But the client still wants to be working with this specific therapist. So, sort of as an adjunct to the work that they're doing with the therapist, they can come and see me, and we get to work more on the like eating disorder specific issues that are coming up for that person. So, those have been two of the biggest places that I found for marketing.
That's wonderful insight. And I do agree, like we were saying before with interdisciplinary team members, like think about if you are in the field right now or you are whatever your business wants to be, think about how you can align with people that are somewhat like-minded and or how you can be of service to support an already existing clientele if they don't have the means to do so. So I love that. Thank you so much for sharing that, Quinn. With the time that we have left in our conversation, what does the future you look like? Where do you plan on seeing, whether it's your business, your practice, your services, anything else you want to share in the grand scheme of either dietetics as a profession, health sciences as a whole, etc.?
One thing that I have been slowly adding into my practice more so, and again, this is one of those things that I did not plan to add in. I just started seeing so many clients who came in with the same health issues, has been Mast Cell Activation Syndrome. And that, in conjunction, a lot of times my clients will have that in conjunction with things like dysautonomia, Ehlers-Danlos Syndrome, POTS. And so I've been seeing a lot of clients who have this sort of like cluster of health conditions. Also, things like chronic fatigue syndrome. Again, they all kind of tend to happen in a cluster together. And again, this was not one of those things that I sought out to treat or thought I was going to be doing in my practice, but I just started seeing so many clients with it. And mast cell activation syndrome has been one of those conditions that has a fairly limited number of clinicians who feel capable to like treat it. And so I think it's a big space where more clinicians need to be educated on because there's a ton of like newer research that's coming out about it. But that's definitely something that's sort of the next horizon for me.
Yeah, I was going to say for sure that's not a chapter in any of our textbooks when we're in
No.
our curriculum. Will you explain a little bit for people who might not know what that is? What is it categorized under? Like what organ system or what kind of approach are we taking with that?
Mast cell activation syndrome is interesting because it is multi-organ system. And I think that this is why people have such a hard time getting diagnosed with MCAS is because of the fact that you can have all of these other symptoms that seem to mimic other health conditions. So GI issues, migraines, hives, a lot of kind of like allergic reaction things, like maybe a little bit of anaphylaxis. And so people get really confused because they go to an allergist and the allergist is like, you're not actually allergic to anything. Or they go to a neurologist and the neurologist is like, I don't know why you're getting migraines. And so they're going to all of these other clinicians who just cannot pinpoint the exact underlying cause of why it is that this is happening. And I think so common with our healthcare system that we're not looking at the whole picture. And so when I have a client who comes to me and they're like, I have all of these symptoms that are going on simultaneously, the like little flags are going off in my head of like, oh, that could be MCAS. You should get evaluated for MCAS.
This is not something that is like a lab diagnosis. It's kind of like a ruling out of other things, or in some respect, like
Or
if
like
then it's
some lab
accumulation.
yeah,
Okay.
there's some lab diagnoses that they have, but there's a lot of debate as to which lab diagnoses are actually useful for it. And so a lot of times I think it does kind of turn into a ruling out where people are just like trying to find other diagnoses. And when they can't find it, then it's oh, okay, this actually might be MCAS. And so a lot of times it turns into let's start treating it like it's MCAS. And if it starts to get better, then odds are it was MCAS.
Then ding ding, we got it. My next question for you is there anything that we haven't discussed? Any hot topics, words of wisdom, or anything that I didn't ask you that you feel might be important in our discussion that you'd like to share with our audience?
I think that the main thing that comes up for so many of my clients that I think is important for both clients and patients to hear and for practitioners to hear again is the importance of listening to lived experience. I just have so many clients who come to me feeling really frustrated because they feel like they're not being really heard in the medical system. Sometimes it's just, the lack of time that clinicians have to spend with them. There's insurance coverage. There's so many things that can lead to that. But I think that this is just something, again, that like clients knowing how to advocate for yourself is so important, and for the clinicians or for the students understanding what we can bring to sessions or to conversations with our patients and clients to make them feel like they're really being heard.
I want to add to that too, because in my own personal life, I also kind of quote unquote caregive with my mom. And there's so many times that I go with her to the doctor's offices. And I feel like if I weren't there, she would have no clue what is going on in that conversation. They don't use lay
Yeah.
terms, they don't explain things. They make her wait, 2.5 hours. They see her for 6 minutes when she's in there. And it just feels like
Yep.
rush, 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 and off you go. With a couple of exceptions. She has a wonderful nephrologist, but a couple of other ones are a little wonky. So I definitely want to add to that by saying sometimes patients don't know what they don't know. They don't know the questions to ask. And I am always a fan of show up with like a notebook and a pen or like on your phone, like
Yes.
like capture some notes, or when you're checking out, ask, can I get a printout? You're allowed to look at your charts. Can I get a printout of what the notes were or what the diagnosis was or what my lab results came back in because the doctor mentioned it, but I'd like to see like at a glance so I can keep it on file. And then you can ask, like, can you clarify that? I'm not sure I understand that. And I mean, Quinn, this goes without saying too, in the better world of dietitians and providers, we will make sure, do you understand what we're saying? Like, we want you to have that reflective listening, open-ended
Yes.
discussion. Let me get feedback from you. But not everybody may have the time or ability or maybe experience or education to know to do that. So I'm not faulting
Yeah.
anyone, but as you said, as the patient advocacy part of it, it's like come prepared and just feel if you can ask as many questions, ask them to explain what that means. And informed consent is a big thing too. If you are struggling with something, and maybe you can speak on this also, Quinn, where if you are struggling with something and you're given options of supplementation or pharmaceuticals or whatever, just make sure like how long, how much, how often, is this a lifelong thing, the side effects. So many people show up to my office where either they weren't even explained what their diagnosis was, and it could be simple as like high cholesterol. Like what is that? Or they were put on meds and then never told, like, oh, this is actually something like vitamin A or D supplementation, like mega doses. That
Yeah.
needs to be monitored. You can't just be on that lifelong
Yes.
forever. So, stuff like that, you really have to make sure you're checking in and understanding what the risk benefit kind of outweighs there. And then this way you're weighing in on your own treatment plan too, and making that something that is responsible on both ends. Like you have that mutually beneficial discussion going on.
Yeah.
Did you want to add a little bit
Yeah.
to that, Quinn? Whatever your insights.
Yeah, I mean, I see this so often with my clients that they come in and they're like, the doctor told me this lab was high. And I'm like, do you know what that means? And they're like, absolutely not. Or the doctor recommended this medication. And I'm like, do you know what that does? And they're like, nope, I have no idea. So I do find, as this is one of those things kind of we were talking about, like education outside of our boxes as dietitians. I feel like as dietitians, we have to have knowledge of a little bit of everything because I have to know about the types of medications my clients are taking. Or if a doctor is recommending a medication, I need to be able to like help educate them on what that medication is going to do. If they have labs coming back, I need to understand what those lab values are because I have more time than their doctors usually to like sit and explain things to them. And so I find that that's really helpful. I always tell my clients if you do not feel comfortable with a recommendation that was given to you, get a second opinion. Could always get a second opinion. That is your autonomy to go talk to other professionals. I also tell them to try to find peer support spaces with people who are going through similar health diagnoses or things because those people have been through this process already. And so they might have some additional information that they wish that they had had earlier on in a diagnosis or something that you can then take away from those conversations with them. So I also think that's a helpful resource for people to have.
Yeah, I think this brings back that discussion, like you just mentioned, of expanding our knowledge on things. So even if you are a dietitian or you're entering into the career and you're like, ugh, I can't be dealing with clinical, like I said myself, I don't want to work in a hospital. I don't want to put in the time and I want to walk
Yeah.
right into outpatient community, whatever counseling stuff. You still need to know what's going on with the clinical stuff. So I love that. Like, learn about the meds, understand what those things are, how they interact with each other. I mean, that is sort of stuff that we did learn in school, but we might not implement it if we're not in a hospital setting. We don't see it as often, but people are on meds and they're coming to you for counseling. And then also, like you said, on the patient's end of things, making sure you have a list of all those things too, whether it's something you don't even, oh, I'm taking, an herbal supplement from something, write something down, have a list on you at all times, because you never know if there's going to be an interaction or something having a side effect that you're not sure about. And then you can kind of look back and say, oh, there we go. That's the culprit. Quinn, my final two questions, technically my two-part pun intended question is, what is on your plate today? So we're at the end of the week, we're kind of mid-afternoon. As soon as we wrap up together, what is the next thing that you'll be working on? And what is the next meal that you're planning for yourself?
Well, I just had lunch. I had ramen for lunch today. So I still need to plan what's going to be for dinner later tonight. But on my plate for the rest of the day, I do have a team meeting for one of my clients. So I'm meeting with some of their other outpatient clinicians that we always like to make sure that we're like touching base. We're all on the same page with things. And then I have one more client session and then I'm off for the rest of the day. So not too much more for the rest of my day.
Quinn, it's been a real pleasure getting to know you and learn a lot more about what you do. And I'm sure that the people who are listening to or watching this episode are going to come away with a lot of great information. At the very least, we've empowered people to ask more questions and gain some more insight and be comfortable and taking in, hopefully as best as they can, taking control of their health, but also who they're working with in their healthcare team. And for those of us in the healthcare space, I hope that this also encourages you think a little bit outside the box, continue working and improving yourself as best as you can. So thanks so much for being on here with me today, Quinn.
Thank you for having me.